A blessed evening to one and all. We are happy to welcome everyone to this Cardio-Obstetric Masterclass with one of the most important topic of concern to be discussed today. I now request Dr. Justin Paul, the course director, to share a few thoughts on Cardio-Obstetric Masterclasses and today's session.
Very good evening, all of you. I thank and welcome all the panelists, the speakers, the moderators, and the attendees in particular. This is a new venture that we have started out, Cardio-Obstetric Masterclass. Welcome to the second Cardio-Obstetrics Masterclass. This was started with an idea that we can improve the care and the support that we are able to offer to any woman with a heart disease whose desire is going through pregnancy or who is going through pregnancy, so that we can provide the best possible care that we can provide in our country, and we can enable these women to enjoy the joy of motherhood. With this noble intention, this webinar masterclass was started, and thank you all for joining us today. And as you know, this is a multidisciplinary panel and a multidisciplinary teamwork. So much is important. So always in our panel, we'll be having a cardiologist, an obstetrician, an anesthetist, in particular an obstetric anesthetist. With some of the diseases, we may bring in a cardiac anesthetist as well, and we may get a neonatologist or a pediatrician as well. So this is a very noble intention that we have joined, and please remember and mark every first Friday, 8 p.m. to 9 p.m. Indian time, the webinar will be on Cardio-Obstetrics Masterclass. And once again, I welcome all of you for having joined us. At the end, we'll be giving you a feedback mail to you. Please reply by the feedback so that we can improve, so that we can cater to the needs of the country. Thank you so much. I hand it over to Annie to introduce the speakers and panelists.
Thank you so much, sir. So we'll quickly move into the webinar. Just a minute.
You can share the screen. Not able to share.
Yes, sir. One second. Sorry.
It's okay. You can just discuss without sharing. No problem. You can discuss.
So I'm very happy to introduce the moderator of today's session, Dr. Geetha Kandavello, Senior Cardiologist, Pediatric Cardiologist, and Director, Adult Congenital Heart Disease Services, National Heart Institute, Jantung, Negara, Kuala Lumpur. Her experience is in adult congenital heart disease, pulmonary hypertension and heart disease, Marfan's and heteropathies. She is the president of the International Society of Adult Congenital Heart Disease, an immediate past chairman of the Malaysian Pediatric Cardiology Society. Glad to share that she's also involved in developing the Malaysia clinical practice guidelines on pulmonary arterial hypertension, pregnancy and heart disease, and prevention of and management of infective endocarditis. She is a member of the National Confidential Inquiries in the Maternal Death in Malaysia. She is also the advisor for Pulmonary Hypertension Association, Malaysia, and an executive member of Malaysian Congenital Heart Foundation. Thank you, ma'am, for joining with us. Now coming to our panelists, Dr. T.V. Chitra Bhatt, Professor of Obstetrics and Gynecology, PSG Coimbatore, Tamil Nadu. Dr. T.V. Chitra is trained in urogynecology and is a skillful surgeon. She is a member of the ICOG, IUSOG, and the past president of Kowai OG Society. She has special interest in high-risk pregnancy management. She is a very passionate academician with years of experience in undergraduate and postgraduate teaching and a recipient of several Best Teacher Awards. She has chaired various national and international conferences. She conducts postgraduate training programs and refresher courses, benefiting a number of budding doctors. Dr. Shibba Chhabra, Professor of Cardiology, DMC Ludhiana, Punjab. Dr. Shibba is the first female interventional cardiologist practicing in Punjab. She is the editor-in-chief of the Indian Journal of Cardiovascular Disease in Women. She is the convener of the Pink Women Cardiology Council of Cardiology Society of India and the director of the WinCar Association. She has bagged several awards for her pioneering work in women health. Next, we have Dr. Aruna Parameshwari, Professor and Head, Flow Leader of all operating rooms, Department of Anesthesiology and Pain Medicine, Sri Ramachandra Institute of Higher Education, Chennai. She is a Vice President, AOA, Specialist Board Member, DNB, peer reviewer of the Indian Journal of Anesthesia and the Journal of Anesthesiology and Clinical Pharmacology. She is a Governing Council member, RSACP. Most vibrant anesthetist, she has given more than 200 lectures at national, regional, and international conferences and has conducted more than 50 workshops and conferences. She has more than 20 publications and authored many books. She has special interest in cardio-obstetric anesthesia. Now, I would like to introduce a speaker for the day, Dr. Krishna Kumar, the Professor and Head of Department of Pediatric Cardiology at Amrita Institute of Medical Sciences and Research Center, Amrita University, Kochi, India. He established the Pediatric Heart Program at the Amrita Institute of Medical Sciences in 1998. Under his leadership, this program acquired a global reputation for the quality of clinical services, research, and training. The Pediatric Heart Program at AIIMS Kochi was awarded the BNJ Award for Quality Improvement for delivering outstanding clinical outcomes and has trained a substantial proportion of national workforce in pediatric cardiology. The department was also awarded the status of Center of Excellence in Research by ICMR. His chief research interests relate to epidemiology of pediatric heart diseases, developing cost-effective clinical strategies and population-based program for pediatric cardiac centers in low-resource environment. He is a member of the steering committee of International Quality Improvement Collaborative on Congenital Heart Disease and has served as a member of Rheumatic Fever, Endocarditis, and Kawasaki Committee of the Council of Cardiovascular Disease in Young of the American Heart Association between 2017 to 19. He has published over 250 indexed original and reviewed articles and edited 4 major textbooks. So before we move to the session, I request the audience to post your questions and we'll be looking forward to answer your queries during the panel discussion. We'll also be having a live Q&A session after the lecture. And please stay tuned. We'll be having a take-home message by the course director at the end. So now I hand over the session, that is Management of Pulmonary Hypertension in Pregnancy, for moderator, Dr. Geetha. Over to you, ma'am.
Thank you, Annie. Very good evening, ladies and gentlemen. It gives me great pleasure to be here today with such esteemed panelists to discuss a very important topic, which is pulmonary hypertension in pregnancy. And without further ado, I'd like to invite Krishna Kumar to share his case.
Thank you, Geetha. Again, a real privilege to be part of this very important, as Justin said, extremely important and until recently quite neglected area of cardiovascular disease. And the whole notion of multidisciplinary care is a bit new to this country. We are only now learning to embrace it, and it's something that we've been doing at Amrita, but it's overall not something that has been widely accepted. So working in partnership, in close collaboration with our colleagues is what I think Cardio-Obstetrics is all about. I've been introduced as a speaker for today, but I'm actually just presenting the case. And we have some very extraordinary experts here who would shed light on how this should have been, how this can be managed, how this case can be addressed in a number of other settings as well. So this is a 27-year-old woman when she presented to us. That was, we're starting this history from 2019. That is the point from where we're going to begin her story. It's like a movie. There is a flashback, and there is going forwards. We'll tell you what happens. This patient was known and was followed up in our institution as atrial septal defect with severe pulmonary hypertension, and she was on antipulmonary hypertensive medications, which included phosphodiesterase inhibitor, tadalafil, in 40 milligrams, and endothelin receptor antagonist, which is ambrisentan. These two medications were being given together, and she was in functional class 2. She didn't have any syncope or presyncope. There was no evidence of heart failure, and she didn't really require any of the heart failure medications. She wasn't desaturated, and she had a reasonable resting heart rate of about 83. Her baseline echo showed a really large AST, 23 millimeters, and with the consequences of a large AST, which was a large right atrium, right ventricle, and main pulmonary artery. We did think at that time that there was subtle evidence of right ventricular dysfunction, as just looked as it appeared from the appearance. But objectively, we didn't find evidence. Of course, the patient had a severe pulmonary hypertension, as indicated by a right ventricular systolic pressure of 100 plus the right atrial pressure. That means like near systemic pressures, like what you would get with the normal systemic arterial pressures. We had those kind of numbers in the pulmonary circuit. So this was her story. And then, of course, this ECG was obtained around that time, which shows right ventricular hypertrophy, just to get you familiar that there is evidence of right atrial enlargement in the form of QR complexes in V1 that suggests that the right atrium is rather enlarged. Her X-ray from the past, not during this index admission visit, but from the past, showed, of course, evidence of severe enlargement of the right pulmonary artery, as you can see, all the way going down with also enlargement of the main pulmonary artery and the left pulmonary artery. Notice that there isn't any significant cardiac enlargement overall, but there is right atrial enlargement. So this is sort of the flashback. Her story actually with us began in 2013 when she presented with exertional dyspnea. She was 21 years, a young student working in our own hospital at that time. And she was evaluated and found to have a large AST. There was pulmonary hypertension. There was a lot of controversy in the decision, but the final decision was to close the AST, but leave behind a hole. She was taken to the OR and given a ASD closure with a patch fenestration. I remember being called to the OR and she wouldn't come off bypass. So I suggested that the fenestration be substantially enlarged, but that also didn't work, and we had to take off the fenestration altogether, the patch altogether, and she then did well, actually, got extubated the next day, and she was doing well overall on follow-up with reasonable status, stable status, and discharged on the medicines that she's currently taking. So that was a past story. Sorry. Now the question, I think we can put it across. She is married now. She desires to have a child. And the question that we're trying to ask is, can she get pregnant? And at this point, we're going to ask Vikrant to put up the audience poll.
Poll 2. Vikrant, put the poll 2.
The poll 2 is visible.
Yeah, it's very much. Thank you so much.
Right. Fine, 30 seconds. We can close the poll.
So we can end the poll now?
Yeah, we can end the poll. We have a reasonable idea for the audience feel.
Results, which is showing. Justin, you want to talk about it?
Yeah,
Or,
I will moderate. So generally, we have majority, about 51% saying that she's too high risk for pregnancy. But interestingly, almost 40% feel that she can get pregnant. So thank you, Dr. Krishna Kumar, for sharing that very challenging and interesting case. Let's see what our esteemed panel has to say. So I'd like to open this question to the panel. We'll ask Dr. Shibba first, because she's the cardiologist and the patient probably would come to her first. So Dr. Shibba, what are your thoughts? Would you allow this patient to get pregnant?
She's 27 years old. She's married, and we have all seen that she's having pulmonary arterial hypertension, and she is on embricentin and tadalafil. So at present point of time, when she is receiving these drugs, it's a matter of concern whether we can allow her actually to conceive, given the teratogenicity which is associated with the embryo. So if she comes to us, we would definitely guide her that probably she shouldn't be going for this. But at the same very time, we also need to understand it's not just the drugs which are important. The basic underlying disease of pulmonary arterial hypertension in itself falls in WHO class 4. And we understand that it carries very high mortality. Given the maternal mortality by the previous studies to the tune of 30 to 56% maternal mortalities, which are known to occur in patients with pulmonary arterial hypertension. No doubt in the last decade, the mortality, the maternal mortality has come down, and it is somewhere, reported even by Silva et al. And other studies to be somewhere around 2 to 3% in some isolated cases with mild pulmonary arterial hypertension, but still said that that is a greater number than as compared to patients who do not have pulmonary hypertension. So pulmonary arterial hypertension, given its effects on maternal mortality, given its effects on fetal outcomes, the premature deliveries, the IUGRs, the fetal demises, and this patient per se comes in MWHO class 4. So she's going to be very high risk. We need to discuss and share as per the recent guidelines by ERS also.
Thank you, Dr. Shibba. So can I just get the obstetrician's point of view, Professor Chitra?
Yes, ma'am. Thank you, ma'am. Like how Dr. Shibba said, it's a very difficult decision to take. It's important that you involve the family as a whole. Tell them about the mortality rate, because initially, whenever we see a patient having a report as pulmonary arterial hypertension, we're going to tell them, don't get pregnant. But now we know that the mortality rate has come down. So every woman would definitely want to get pregnant. That would be her dream. So we really have to balance. And moreover, this particular person has a functional class 2, which is really not so very bad. So you really have to counsel her and her family and tell her all the complications which has been listed out so far. Tell her all this can happen. She can even end up in a mortality. Are they willing to take the risk of going through the pregnancy and, saying that her life might end also? So it's very important that you discuss with the family, and then they have to take a call, because very often when you tell these individuals, don't get pregnant, promptly within 6 months, they'll end up with the pregnancy. So how much ever you tell them, the fear has to be installed not only to her, but to the family members and the husband is what I feel. And it definitely carries a lot of mortality, but we have to counsel them that it is possible that now in recent days, the mortality might be a little better.
Yeah, thank you, Professor Chitra. So if I conclude from this discussion here, generally, the pregnancy risk is high. WHO class 4 mortality can be anything up to 30 to 50%, even though today the risk has been shown to be less if well managed. So the patient needs to be well counseled. It should be a cardio-obstetric counseling together with the family. And at the end of the day, consensus decision is made between the patient and the expert team managing the patient. So, Dr. Krishna Kumar, can you tell us what happened to your patient? We can't hear you, Dr. Krishna. I think you're muted.
So I'm just showing the risk stratification, and I think Dr. It was mentioned this patient falls in category 4, MWHO 4. That is the highest risk in this particular scheme of things. And of course, there is this risk of mortality that is considerably high in these situations. And event rates are also considered to be considerable. And the other prediction model also suggests that this patient is at substantial risk. Which is the CAR-PREG2 prediction model. So at 27 years old, she conceived spontaneously, and she was on dual therapy with ambrisentan and tadalafil, and she presented at 14 weeks gestation. And the question that we are asking the audience now is to whether terminate or allow pregnancy. Justin, you can...
Poll 3.
There is poll 3, yeah.
Vikrant, can you post poll 3, please?
No, 4 trees.
Yeah.
So I think it's a wrong question, sir.
4 trees on the toxicity.
Actually, we are not asking this question. We are asking this question later on. But still,
Okay.
you could
It's
do
okay, let
this.
us get, yeah.
Let's go with it because it's still relevant to this particular question, and
And
we can sort of
we can take
adjust
poll
our-
4 also after this. You, Dr. KK, you want to take the next one also?
I think we should do both the polls after this. We should do this poll and then the next poll.
So thanks, Vikrant. You can display the results in poll and then show the next poll also.
So just to conclude, the question basically is about fetotoxicity of the pulmonary arterial hypertension drugs. So here, 3 groups are discussed. The PD5 inhibitors, which is tadalafil, sildenafil, the most common. There's also a newer drug called riociguat, which falls into this group. Prostanoids, which are your selesipag, your inhaled iloprost, your treprostinil, your ibuprostanol, and your endothelin receptor blockers like your bosentan, macitentan, ambrisentan, like the patient is on. So the question is, which are this group are fetotoxic? And as you can see, the split is between the PD5 inhibitors and the ERBs about 40% each, and prostanoids 19%. So I think it's important later, KK, that we'll need to discuss about this and advise our audiences. So can we, do you want to start the next poll? But in the interim, one of the issues that is clearly illustrated in this patient is that she's undergone preconception counseling, and both the doctors have advised, the team has advised her that it is a high-risk pregnancy, yet she has come back now on treatment and pregnant. So maybe I can just ask, before we go on to discuss whether to terminate or allow this pregnancy, I'd like to ask the expert panel about why this happened and what we could have done better to have prevented her coming pregnant, because we want to ensure that these patients do not come with unplanned pregnancy. So I'll start with Professor Chitra here, because she's pregnant. She'll see the obstetrician first.
Now, this particular person most probably would have been lost for follow-up. In spite of telling she would not come back to the obstetrician or come to the hospital, that is the reason why she's become pregnant. And moreover, because the more she comes to the hospital, the more we're going to tell her don't get pregnant. So quietly they will stay at home and then get pregnant is what happens really. But once she becomes pregnant and she's come to me at 14 weeks of pregnancy, she's taken all these drugs. I definitely would not want her to continue the pregnancy. I would definitely say it is better that you terminate the pregnancy, because you've not assessed her risk initially, and the drugs, we don't know the teratogenicity. So it's best that at this time I would definitely counsel her for termination of pregnancy.
So Professor Shibba, what are your thoughts?
I agree with Dr. Chitra that at present point of time, it's 14 weeks of gestation, and she's just 2 weeks apart from the first trimester, and she's been on a drug like ambrisentan, and though we have seen the audience polls, the teratogenic effects of any possible drug in first trimester are worrisome, all the more for endothelin receptor antagonists, and also riociguat if at all the patient is on it. Besides that, I think preconceptional counseling, and even at this point of time, counseling is very important given the high mortality of the patient, maternal mortality per se, which is attached. And we need to counsel the patient about what she can expect in terms of her as well as the fetal outcomes, given higher rates of IUGRs, fetal demise, and preterm births, and which can be attached. So I would rather say that at present point of time, I would try to convince the patient and the family to kind of terminate the pregnancy, because it's not good for either her or for the upcoming neonate.
So how would you assess this patient to determine the potential risk of the deterioration? Because we know patients with pulmonary hypertension, they have a wide spectrum. And this patient, if you
Right.
at the
So, yeah. So whenever we have a given patient of pulmonary arterial hypertension, risk stratification of the patient becomes very important. So the first thing which is very imperative comes as the functional class of the patient. Now, this patient has been in functional class 2. Besides the functional class, if this patient was in functional class 3 and 4, it was always a big no-no which is there. The patient can also be assessed in the terms of, the 4-point scale, which has been mentioned by the European guidelines, which includes the, not at this point, but maybe antenatally, the 6-minute walk test, the NT-proBNP and the BNP levels, which are there. And of course, when this is the patient, we can kind of do her echocardiogram, look at the pulmonary pressures, look at mild, moderate, or severe pulmonary hypertension. Less than 50 falls to be mild, and 50 to 70 or 80 is something mild to moderate, and more than that becomes severe pulmonary arterial hypertension. The patients can be classified not just into mild, moderate, and severe, but moderate can be further classified, or the intermediate risk can be intermediate or moderate, intermediate, or high risk. So having classified our patients into these 4 different categories on the basis of their functional class, and then looked at their echocardiograms for any evidence of RV dysfunction, which could be done by looking at their TAPSEs, or maybe looking at the RV-FAC, which would include longitudinal as well as circumferential strain. And not at this point of time, but intermittently, even CMRs can be of help in these patients to risk stratify them and assess at what level they are. In this particular patient who is 27 years, who is in class 2, who's already on drugs, I would definitely try to counsel her not to go further with this pregnancy, and she should kind of terminate.
So, would you all invite Professor Aruna to join you all in this counseling in terms of whether to continue or terminate the pregnancy? Would you bring in your anesthetist early now into the discussion? How about Dr. Chitra? Is that part of the practice?
Definitely, ma'am, because once you decide on termination, we have to choose on the method of termination. Methods of termination could be either medical methods or surgical methods. So we have to choose, is this particular person fit enough for a surgical intervention, or does she require a medical management? If you want to go in for a surgical intervention, so the first option would be to send her to a cardiologist and ask them, is it safe to give them these drugs, which we normally use, which is your mifepristone and the mifegest. Is it safe? We have to ask them. Supposing they say it is fine, then maybe we could go ahead with the medical termination. But we have to be very careful that even in that event, 85% of them might succeed in having a termination, whereas 15% of them might go in for a retained process of conception, in which case you may have to have a surgical intervention. So for that, we definitely have to ask an anesthetist and tell them that this is a patient that we have. So in case we require a surgical intervention, would you like to see the patient and would you like to assess her? It's very, very important, because we know we can't call them unexpected and say we're bringing the patient, we're billing her inside for a DNC. If something happens, so they should be well prepared, because she's having severe PH. It's very, very important that even before you touch the patient, both the anesthetist and the cardiologist should be involved, because we do not know what is the side effect of all these drugs, how they're going to act, because though we use them very frequently, how exactly it's going to happen on the heart and the pulmonary vessels, we do not know. Whether mifepristone and misoprostol, they say it can reduce the pulmonary arterial hypertension, but we have hardly any, we are not experienced so much. So we really have to get their opinion, and it should be a combined effort at this stage, both the cardiologist and the anesthetist, I feel.
So, Professor Aruna, what are your thoughts? They now invited you to come and assess this patient and to plan for termination of pregnancy. Can you share your anesthetic concerns, planning, and how would you prepare the patient pre-termination, and how would you take the patient through the termination of pregnancy?
So the preoperative assessment of the patient, most of which was Dr. KK has told. So we look at the clinical examination of the patient, what are her symptoms, what is the functional capacity, and we would like to know what are the current pulmonary artery pressures after putting her on treatment, what is the latest status of her, what is her oxygen saturation, and we also have to look at all the investigations. Is her hemoglobin okay? Is she not into any coagulopathy? So we look at all this. Now, if you look at the options, she is definitely high risk because of severe pulmonary hypertension. Normally for MTP, the two types of anesthesia we normally give is some amount of sedation, or it could be done with a full-fledged general anesthesia or a neuraxial anesthesia. Now, the problem in giving it with just a mild amount of sedation is going to be, we do not want any hypoxia or hypercarbia, and most of these drugs are respiratory depressants. The only thing which is a non-depressant is IV ketamine, which is actually contraindicated because it increases the pulmonary vascular resistance. So the best option in this patient, if she comes for an MTP, is probably to give her a neuraxial anesthesia as long as she doesn't have a coagulopathy. We do not need the level which we would need for a cesarean, where we need a T4 level, and the sympathectomy is much more. Whereas for an MTP, we need a level of only T10. So it is possible to give a small dose of local anesthetic, combining it with an opioid into the intrathecal space, so that the patient does not have a very severe sympathectomy and fall in blood pressure. Saying that, some other things are very important. We need to have supplemental oxygen provided at all times because it's a good pulmonary vasodilator. Then we make sure that monitoring is in place. We'll have minimum ECG, 5-lead ECG, pulse oximetry, and we also use invasive arterial blood pressure monitoring so that we can pick up hypotension earlier in case we want a vasopressor infusion. Fluids, again, we have to be very, very careful. Even for an MTP, we make sure she has to be euvolemic. You don't allow a hypovolemia or a hypervolemia. So all this will be discussed in the multidisciplinary team meeting with the patient, as well as with the obstetrician and with the cardiologist. So we have a structured, tailored plan in place before we take her to the operation theatre.
So how about the nursing counseling? Because if you're doing a medical termination, the patient is going to go through some degree of Valsalva, and then she's going to expel the product of conception. So we do know when she goes through the pain, I mean, if you've given good anesthesia, she's not going to have pain, analgesia, but the management around that time, because she will feel like bearing down, and that can increase her pulmonary vascular resistance. She can have changes in the hemodynamics at that time. So what are your counseling to your nurses or to the young fellows or doctors who are on call or who's around the patient at the time? Because we never know when she's going to go into that delivery point, right? When she expels the POC. So how do you counsel or advise your nurses and the doctors, the young doctors who are on call? Maybe we'll ask Dr. Chitra, and then maybe each one of the experts can share their point of view.
At 14 weeks, the baby is hardly 50 grams. So she may not really require to push out so much. It's a very small fetus. So at that time, she may not really have to use much of a Valsalva, is what I feel. If it's a larger baby, more than 20 weeks, she might have to strain. But this time, it just comes out like that. So she may not really have to strain so much. But anyway, it's very important that all patients must be monitored because we have given them some drugs. So you should have a person, a staff nurse who's trained in a little bit of intensive care. You just can't have a routine nurse there because it's very severe pH. So ideally speaking, if I have a cardiac nurse available, that person would be the best person to be with the side of the patient to monitor, because we do not know suddenly check this, check that, and she should be connected to all the monitors. So it should be a person from the cardiac ICU is what I feel.
Yeah, so basically the communication should be not just expert team, but right down to the nurses and to the fellows on call. So let's move on. Now the patient, KK, can you share what happened to your patient, please?
Yeah. As she's, I think we'll skip that question and we'll move on to discussing what happened. At 27 years, she conceived spontaneously. And as I said, she underwent MTP, but actually, interestingly, she underwent MTP at another hospital, which we weren't very happy with, but fortunately had no events during the MTP. And then she came to us. And we really strongly counseled for contraception and suggested either a IUD or a progesterone-only pill. But she didn't actually follow up very well for the next 3 years. She remained in class 2. She was reasonably well, but she wouldn't come, as was pointed out, that because we kept reinforcing the dangers of pregnancy. At 31 years, she conceived again, but she planned this. She stopped ambrisentan by herself. She's a she's a paramedic, so she knew all about it. And she stopped it by herself for 6 months and then conceived. And then she came to us.
Okay, so now the patient has already decided that she is going to pursue this pregnancy. And she's come at how many weeks, KK, now when she first came to see you?
She was at 7 weeks when she came to us.
So she
Very
came,
early.
yes, she came early, but she has decided that she's going to continue this pregnancy. So she will probably see both the cardio-obstetric team first. So we'll ask Professor Shibba how you would manage this patient at this point.
Well, now that she has come and it's been a planned pregnancy and she's a paramedic, I would still try to, counsel her once again, because a shared decision is very important. I would again remind her about the associated risks which can be involved, because all said and done, PAH, whatever form, still falls in class WHO4. And however, if she is insistent and she kind of does not agree, because which we understand that we had done it before also, then after having explained her the risks, I would like to assess her. At present point of time, she is in functional class 2. Her saturation is good. She has severe pulmonary arterial hypertension. However, her right ventricular functions are well preserved. So we need to the patients who are in WHO class 4 by the guidelines, we need to follow them up very astutely. So it has to be minimum of a monthly follow-up, which would be advised. And if she is very symptomatic, maybe even earlier, we need to follow her up on the basis of her symptoms, on the basis of her hypoxemia, and also echocardiographic features of any development of RV dysfunction, which could be in the form of TEPSE. I could also monitor her with her BNP or NT-proBNP levels. So I have to tell her that this pregnancy needs to be continued. I would definitely advise her to meet the obstetrician and enroll the cardio-obstetric team at this point of time, because we understand the importance of MDT, which Dr. Aruna just now mentioned, that is multidisciplinary care, which is very important. And this is the right time that we should all come into picture and work into consortium if she insists to continue with the pregnancy.
So KK, can you go on to tell us what happens, and then we'll ask our panelists about what are their concerns. So basically managing this patient and through her pregnancy means anticipating potential risks and the time that this is expected to happen, and it would be based on the changes that occur during the pregnancy, normal cardiovascular changes. So maybe Dr. Chitra, from the obstetric point of view, what would your concerns be? When would be the peak period that you expect things to happen?
So we expect the peak, so her symptoms to happen when the maximum cardiac output occurs. So normally we expect it either anytime, even after the end of the first trimester, but it could normally occur around 30 to 34 weeks of pregnancy also, because of cardiac output actually it reaches by the end of the third trimester, by the third month itself. So we should be prepared. And moreover, this particular person is at a high risk for developing, thromboembolism. That's another problem which can happen to her. In addition, as far as obstetrics is concerned, she could develop preterm labor, other complications like preterm labor, abortions, FGR, and preeclampsia, thromboembolism. All this must be counseled to the patient. We really have to discuss it. And it's always a multidisciplinary action, because we do not know what are the side effects of all these drugs, what is her status, cardiac status. So every time when the patient comes, it is important we send her to cardiac, get a cardiac opinion, and then evaluate her properly. That is very, very important. And we need to know, we should also have a discussion with the cardiologist to find out when should we really find out what are the signs which tell us something is wrong with her? Because she might have various symptoms which mimic her worsening of pH, which we may not know. So it's important to tell them, to ask what all should we look for in that particular person. How do we recognize that she's deteriorating so that we'll be able to have an eye on her.
So the red flags in pregnancy. Okay, so a lot of the symptoms, cardiac symptoms, are similar to pregnancy symptoms. So Dr. Shibba, maybe 3 or 4 red flags, and that you would want to give some advice to your audience, as well as you want to advise or warn the obstetric fellows who are following up these patients or seeing this patient.
Well, of course, the symptoms, edema, dyspnea, fatigability, all of them can actually be mimics of pregnancy. So it's important to have some important things noticed. And some of those things could be inappropriate tachycardia, which the patient is having, or if the patient develops an accelerated hypertension, or the patient is having hypoxemia, which is out of proportion. We saw the saturation was 96%. If there's a fall in saturation, if there's a rise in heart rate, and for a physician to observe if there is a rise in JVP, or if the patient's BNP levels can be done and the BNP levels are actually rising, these features could actually be telling us that our patient is, not a normal, these features are not belonging to normal pregnancy, and probably she is deteriorating. Development of cyanosis can be noticed by the patient herself. So these are some of the red flag signs: development of cyanosis, inappropriate tachycardia, rise in pressures, which the double product which is rising, and of course for the physician to notice at the JVP and a fall in saturation. So these signs should be picked up in time. And if the patient is going from class 2 to class 4 and is very tachypneic, or is feeling that she's not able to perform her routine activities also without an unease, that means that she's in functional class 4. It should be noticed and acted upon immediately.
So Krishna, KK,
Yeah, so that's what happened.
Exactly happening, yes.
Yeah, we waited till 27 weeks and she worsened at that time. She was actually doing quite fine till then. And we've been monitoring NT-proBNP trends. That's our protocol for all pregnant women, all PH women who become pregnant. We monitor their trends, and she had a rising trend and her SAT started to fall. So we knew that she's worsening, even though she wasn't overtly sick, but we knew that she was worsening. And so the question now is what we need to do now.
So back to the expert panel, 27 weeks as expected, when the peak cardiac output, all the symptoms that Dr. Shibba mentioned, worsening functional class, increasing NT-proBNP, saturation dropping. So now the patient is back to all 3 of you. What would you do now?
Shall I?
Yes, we'll start with the obstetrician, because you have come and seen the obstetrician now.
Yeah. So now she's almost reached 27 weeks. Another 1 week or so, she would be reaching 28 weeks. So having gone through this pregnancy so far, I would definitely try to say, is it possible to wait 1 more week, provided the cardiac, the cardiologist tell me, okay, fine, we will take her, we will look after her for 1 more week. Then maybe I would definitely try to push her for another week, giving her the steroids and whatever is necessary to see that she has the best chance of having a baby, which is viable. So because 27 weeks, 1 more week was possible, and explaining all the risks to the patients, I would try to continue the pregnancy for another week, provided which is quite safe. Definitely give her steroids and admit her in the cardiac ICU, and then watch her carefully until I make the decision of delivery. So
basically a multidisciplinary team discussion at this point.
Yes.
The cardiologist and
Yeah.
the intensivist and the anesthetist. Maybe if you have a PH expert, you want to bring the PH expert in too, to decide whether you can take her through another week or so, or whether we need to consider delivering the patient. So KK, you want to share with us what happened?
Yes. So we actually decided to initiate a drug called Selexipag, which is a prostacyclin analog, which has recently become available in India. And you start this at a very low dose because it tends to be very poorly tolerated if you start with max dose. So typical dose is 200 microgram twice a day, and we increase it progressively over a month to 1,000 microgram twice a day, which is a really large dose, but it's well tolerated if you do this. Although number of side effects have been described, in this particular patient, we did not encounter them. And then she had a symptomatic improvement. Her saturation improved to 95%. And I think at this point, Dr. Geetha, you would want to just discuss options.
Yes, thank you, KK. So basically, at that point when they had the multidisciplinary team discussion at 27 weeks, three things were important. One, medically and treatment-wise, can we optimize her better? The second thing is to anticipate that we might need to deliver her early, so the anesthetic and the obstetric concerns for the baby. And the third thing is whether this patient should be admitted and managed inpatient. So Dr. Shibba, you want to share a little bit about the pH targeted therapy, because now Dr. Chitra and Dr. Aruna are going to ask you, Selexipag, what are the things that they have to be concerned about? What would be the symptoms or side effects that they have to look out for if the patient complains?
Well, yes. So this is the time when the patient has come to us. We do remember that she was initially, when the first go was there, on ambrisentan and tadalafil, on what she was in class 2. And right now she was on a single drug, and we are standing somewhere at 27 to 28 weeks, which we understand is the time when she is started facing the bunch of increased cardiac output with right ventricle, which is already dysfunctional. So we understand that her pulmonary capacity is not able to take that brunt, and we need to come down with her pulmonary pressures. She's already on tadalafil, and we need to introduce another pH targeted therapies. Having discussed that endothelin receptor antagonists are out given their teratogenic effects and not used in pregnancy, and so stands true for risdiplam, we have the options which are left in the form of prostacyclin analogs, and of course Selexipag, which is a newer drug which has been used in case reports only, I would say, in pregnant patients. We do not still have that kind of data which is available with the use of these drugs. Prostacyclin analogs have been tried in patients who are in class 3 or 4, if we talk of inhaled iloprost, and we know that it's so difficult to take it, there are multiple inhalations 6 to 9 times a day, which is recommended with the use of iloprost. We understand that epoprostenol is also available, as is available IV epoprostenol infusions, which can be given intravenously to these patients, especially when they are in class 4 and being treated in a PAH ICU. Selexipag in this kind of scenario, which is in oral drugs, gives us a really very attractive regime. However, given its side effect profile of tolerability and the gastric, the emesis, and the gastrointestinal motility that it can promote, these are some minor concerns which I would say, and that rests just on the tolerability. Otherwise, this drug can be given to the patient who is pregnant.
So basically, the aim here is to try and optimize her care, whether it's pH targeted therapy or other secondary measures like bringing her in, resting, correcting her anemia if she has, bringing down the heart rate if she's tachycardic, heart failure management, and then trying to defer the delivery in a more controlled manner. So KK, what happened to your patient? KK, were you successful?
Just a quick word. Selexipag is a recently, the availability of PAH drugs are somewhat limited in our country, although we are better off than many other countries. So Selexipag is something that's come in very recently. So we essentially have 3 or 4 categories that are available. We don't have the prostacyclins or prostacyclin-like drugs available in India. So this is something that was introduced about 6 to 8 months ago. At 34 weeks, she had further worsening despite being on these medications, and a clear decline in RV function as measured by one of the indices that we use called TAPSE. But essentially, her RV was taking a hit. She was not able to tolerate. And so what do we do now?
So back to the expert panel. So we managed to bring her up to 34 weeks. Dr. Chitra, Aruna, and Shibba, you've been all called together for the multidisciplinary team discussion. You probably also brought in your midwife, your intensive care team, and now you're going to plan delivery for this patient. So we'll start with Dr. Chitra first, because you have to think about the baby. So what are you going to do?
Now that she's reached 34 weeks and she's deteriorating, I have no idea of continuing the pregnancy any further. But I cannot deliver her straight away because it's very important that you stabilize. So get a multidisciplinary team, see that everybody has allocated their particular roles, call everybody, see the patient, and then plan the type of delivery. That is very important, because are we going to give her a vaginal delivery or are we going to do a cesarean section? So since she's declining RB function, I might personally think a cesarean section might be better. But in fact, I have to really discuss with the cardiologist and the anaesthetist. So all put together, we have to discuss what is the way of management, what is the mode of delivery. Is it best that she has a vaginal delivery, or is it best that she has a cesarean section? That would be one point. The second point that I'm concerned would be, if at all she has a vaginal delivery, how are we going to manage her second stage of labor? How are we going to monitor her labor? How long are we going to wait? All that again becomes cumbersome. Is it necessary to allow the patient to undergo through all the things? And what type of labor analgesia are we going to give? Can we give her an epidural, or what sort of drug are we going to give her? Because she might take a longer time, she might take up to 24 hours. So all that has to be discussed. In case she has a cesarean section, if she delivers, if she has a PPA, what type of anesthesia? Is it general anesthesia? Is it spinal? What are the problems that she can have? Any PPH? What are the drugs that we can give her? Because we're concerned if she has a PPH, what drugs? We know all these drugs, ergometrin, we say it's always contraindicated in heart disease. But in this particular person, what do we give? Do we give oxytocin? Is it safe? Prostaglandin, is it safe? So it's very important that we know all the drugs which could be given to her safely. So for our concern, we would definitely like to know the mode of delivery which is best for the patient. Where are you going to conduct the delivery? If it's normal, is it in the theater or is it in the OT? Or is it safer to have a cesarean section straight away with a multidisciplinary team? And what are the complications that we should anticipate, and what are the drugs that we can give safely to her? That would be a concern. I would definitely ask all of them. We should sit together and map out what do we do for this particular person. And we should definitely call a pediatrician also, because it's 34 weeks.
So Dr. Aruna, how would you manage the anesthesia for this patient?
Okay, so now this patient could either come for a vaginal delivery or for a cesarean. If she's going to have a vaginal delivery, then it is very important to have a pain-free labor. So we would recommend a labor epidural. What we use is a very dilute solution of local anesthetic with fentanyl. So we don't have to be so worried about a sympathectomy and hypotension with that. It doesn't cause so much of hypotension at all. Considering that anyway, we need to have all our monitoring, which I said before, all that will be in place. And we have to discuss along with the obstetrician and take it forward to cut short the second stage of labor so that she does not push and have problems because of that. So oxygen, 2 good peripheral intravenous line, a labor epidural and analgesia would be the plan for her, with continuous monitoring with an anesthesiologist being there. Saying that, we also have to be prepared for any eventuality she might develop during labor. So we will have all our inotropes and vasopressors, everything on board, and plan for fluid therapy, everything if it's going to be a labor analgesia. Now, if she's going to come for a cesarean section, the first question is, do we want to do it in the obstetric OT or do we want to do it in the cardiac OT? Because she seems to be having some amount of RV dysfunction. So there are several incidents where femoral artery and femoral vein sheaths are placed, so that in case you want to take her onto ECMO suddenly, then it's easier to just put a guide wire and put the larger cannulae. So if we are planning like that, because she has RV dysfunction and she's worsening, then it is better to do it in a cardiac OT with all these lines in place. Even for this, we would prefer a regional anesthetic. That is any day safer than a general anesthetic, because general anesthesia is going to be associated with positive pressure ventilation, administration of PEEP, all that worsens the pulmonary hypertension. Induction per se, the drugs we use, We have a cardiostable drug called etomidate now. Even with that, induction can be associated with some amount of hypotension, and she might not be tolerating this preload fall. Intubation is a very stressful stimulus for someone who is having an RV dysfunction and pulmonary hypertension. So all this can be avoided if we choose a good neuraxial technique, but we definitely need a central venous pressure line to transfuse into, put all the vasoactive medications and inotropes which are loaded and kept. Regarding a pulmonary artery catheter, it's not being used so frequently for peri-operative monitoring now. More and more, we are relying on transthoracic echocardiography or a transesophageal echocardiography if she had a GA, and point-of-care ultrasound. So we would like to look at these parameters to find out how her RV status is. Regarding the blood loss, she cannot tolerate any blood loss. And if you have uterine atony, there is going to be blood loss. So regarding the oxytocics, methogen is contraindicated, prostaglandins are contraindicated. The only thing we are left with is oxytocin. But even with oxytocin, there are case reports of cardiovascular collapse with a bolus dose of oxytocin. So what we would recommend is just an infusion of a very minimal dose. We would probably start at 3 units per hour. The current recommendation for an elective section is 2.5 to 7.5 units per hour. So we start with the lower dose range and continuously look at the heart rate, look at the invasive blood pressure, and then titrate the oxytocin and coordinate with the obstetrician as to how the uterine contraction is, because we also don't want an uterine atony and the blood loss. So that's something which we can do. And fluid therapy, we have to be very, very meticulous. So we would probably look at the plethysmographic waveform and see the respiratory variations, look at echo and all that, take into consideration and not give a bolus dose of fluid to her because we don't want to overload her. And as I said, the complications which we can develop are, she can have a collapse, she can have an RV failure, she can have a pulmonary hypertensive crisis. So we need to have all the medications prepared and ready in the operation theater. And also she can have arrhythmias, any of the malignant arrhythmias. So the defibrillator pads, all the anti-arrhythmic medication. So the preparation of an operation theater is going to take quite some time. So if we are prepared, then I think we should be able to manage most of these eventualities which can happen intraoperatively.
You have...
Geetha, can I just make a comment?
Sure.
See, like PPH is one of the most important complications which can happen. And like what Dr. Aruna said, all these drugs are contraindicated. So now we have these suction cannulas, especially in Tamil Nadu, even throughout India, people are using the suction cannulas. So it's very, very effective. It contracts the uterus. So maybe this might be an ideal case where we can use a suction cannula. So no drug need to be given. You just have to connect it and the blood loss is going to be very minimal and the uterus will contract well. So maybe this case might be an ideal one for a suction cannula.
Yeah, and also the neonatologist must stand by. She's gone through so much to take the baby to this stage.
Yes. Yeah.
Want to be sure that the baby does well too. So, Kiki, what happened? Did you choose?
So she delivered at 34 weeks.
Caesar.
This was an uneventful cesarean section done as Dr. Aruna described under epidural anesthesia. The baby was a healthy preterm baby with a birth weight of 1.9 kilos. And baby did really well, no problems. And the mom was initially doing quite okay.
So was she delivered in the cardiac OT or was it in
Our theatre complex is all within the same area, not necessarily in a cardiac OT, but the cardiac anaesthetist was there, available on standby. You know, they're all in close proximity with each other, but not in a cardiac OT.
So combined cardiac and obstetric anesthetists with expertise should be there for these deliveries. So now Dr. Aruna, Chitra and Shibba, the patient has undergone elective cesarean section. So we start with Dr. Aruna because you are the one usually after the delivery you'll be managing the patient, transferring the patient to the ICU. What would your concerns be? What would you tell the nurses and the on-call team for the next 24 hours? What would your advice be and what do you anticipate will happen?
Whatever care was given in the intraoperative period, the same extent of care has to be continued for her. So she has to be in an intensive care unit with the same level of monitoring for everything. I mean, for the inotropes, vasopressors, and also for the fluid therapy, monitor for bleeding. All this has to be continued, the same extent of care. whatever was given in the intraoperative period has to be continued, the same amount of care into the postoperative period as well.
So how
Yeah.
long to continue that analgesia support? Because pain is an important factor that can trigger a lot. So how long would you continue the epidural or the anesthetic support? Anesthesia.
The epidural we would keep for at least 48 hours. We can keep the epidural because we are not planning on ambulating. Most of the other patients will try to ambulate the next day itself. We are not planning that for her. So at least for 48 hours, we can keep the epidural in place and make sure she does not have any pain at all.
Okay. Dr. Chitra, from the obstetric side, what would your concerns be?
So immediately, I would like to see her, check her vitals and see how is she bleeding excessively is what would be my concern. And I would like to see is she in a fit condition to feed the baby. The baby is only 1.9. So can she feed the baby is another thing that I would like to know. Most probably the baby might be in ICU, but if the baby is handed over, provided the mother is okay, would she like to feed the baby is what would be another concern. And next would be when can we start on fluids, clear fluids, and early removal of catheter. We would definitely try to follow the eras in her. So is it possible that we can start her on oral feeds much faster and try to ambulate the patient, because which is more prone to develop thromboembolism? And without forgetting, during the cesarean section, I would try to put her in IUCD at that time itself to see that she doesn't get pregnant again. So postpartum IUCD would be something that I would have considered in her when I did the cesarean itself.
And maybe subcute Clexane or something while...
Yes.
Yeah, anticoagulation.
Okay.
Yeah, one thing I would like to add,
thrombus.
if she's going to be on anticoagulation, then we will have to time the epidural catheter removal. We have the ASRA guidelines on what to follow. So depending upon the dose of low molecular weight heparin which she's getting, we will have to discuss again as a multidisciplinary team and plan exactly when the epidural catheter can come out.
So Dr. Shibba, now she's back to you.
Yeah.
Maybe...
So very happy to have her back to me, but at the same time, I realize that it's imperative to understand that this is the time which is most important for her, because maximal events which are there and maximum mortality has actually been attributed and reported in immediate early postpartum and even in late postpartum period. So I need to understand that I have to be very careful lest she develops any arrhythmias, or because of RV dysfunction, she develops any cardiovascular collapse. And of course, I need to be taking care of her pulmonary embolism. Having said that, even during delivery time, I would say that as a cardiologist, I would caution everyone for the fears that I have because of autotransfusion, which occurs, during that. And I need to understand that at the same point of time where I don't have to push fluids, I have to know that my patient has to be euvolemic, given the fact that the RV is dysfunctional and it needs some preload to move on. So this is the time I need to take care of my patient. I need to follow her up regularly. I need to look at her symptoms. She needs to be in a cardiac CCU or an intensive care unit for a minimum of 24 hours or till the period when she gets or regains her hemodynamic stability. The period which is important, as we say, is the 4th trimester of pregnancy. That means the first 12 weeks that occur immediately postpartum. That, of course, is important. However, late maternal events have been reported even up till 6 months. I would like to review my patient. I would tell her to continue with breastfeeding. And at this point of time, if at all, I need to introduce endothelin receptor antagonist in my given patient, I can do that, because that is bosentan is considered to be, it's possible to give it even when the patient is lactating. And of course, I would like to follow up my patients on a regular basis as any other patient of PAH. And again, tell her, counsel her, remind her, and tell her of contraception again, so that she is careful for the next time. And a long-acting contraceptive, maybe an IUD progesterone containing device would be a good option for her. I need to keep all these things in mind. I would also like to mention the use of intrauterine oxytocin, which has been mentioned. I do not have any personal experience, but I read about it when I was undergoing the management of the use of oxytocin in PH, in these patients where we are not able to use ergometrine and prostaglandins.
So as you can see, the most important period here is in the peri and postpartum period, and KK's patient illustrates the importance of optimal and obsessive care in this period. So KK, you just want to conclude your patient, what happened after delivery? And
yeah, we were actually very careful. We did not mobilize her very quickly because she was quite ill. She had a further fall in saturation, requiring oxygen throughout. Her NT-proBNP rose substantially at that period of time. We started inotropes, actually, and needed 48 hours of inotropes. We were forced to keep her in bed, so we had to give her heparin for that reason. And then after 1 week, we could mobilize her and move her to the ward. And we had to keep her in hospital for 14 days, actually, after we were certain that she's out of the woods, which means normalization of saturation, declining trend of NT-proBNP, and normal recovery of RV function. All this had to be done. Only then because we've been taking care of these patients and we've learned from our past experience that you've got to be super careful here. So these are the trends, of what we had with the NT-proBNP. As we see towards the delivery, it actually comes down, but then it rapidly rose back again. And then we had to wait for that real trend to come down before we were comfortable with her. Subsequently, she's been on follow-up, as has been discussed, and she's really doing well in terms of just comparison with her baseline. We've got an echo done, which actually shows that the RV function is not too bad, actually. The PA pressures are, of course, systemic. We don't expect that to come down very much. And she's doing reasonably well. The baby is growing well. And of course, we've also have IUD installed into her. So definitely she will, we hope that she will not get pregnant again.
thank you, KK. So a good outcome for a very high-risk patient. Well done. We want to just go around the room and ask all the panelists one very important message that you want to say about this group of patients. Maybe we'll start with Dr. Shibba.
I would like to tell my patients that PAH, even as of date, is an MWHO class 4. It carries a high maternal mortality and fetal events reported. So a shared counseling is very important for the patient. However, if the patient decides and if the patient is a low risk PAH, we can accompany the patient with a very monitored therapy to be taken a good care, especially in the postpartum period where maximum events are reported. It's a lifelong continuation with a multidisciplinary team.
Dr. Chitra?
Definitely a long-term contraceptive is important. Maybe a long-term IUCD implant, something which is there for 10 years, 15 years. So she has to definitely have all those things. It's important.
Okay. Dr. Aruna?
I would recommend the anesthesiologist to be part of the multidisciplinary planning from earlier on, say around from 20 weeks itself, and be part of the entire discussion. And the second most important thing I would like to say is being prepared to handle all the complications which can happen. That'll actually save the patient, rather than assuming that many people feel that nothing will happen and go ahead and get into trouble. I've seen that. So it's better to always refer such patients to a tertiary care center where facilities are available for the best possible care.
So I just want to add to all this expert opinion is that one, we want to have the patient with us. So we have to be very conscious about not being paternalistic when we're talking about these high-risk pregnancies, telling patients not to get pregnant because we'll lose the patient. If we lose the patient's only going to come back to you when the patient's in trouble. So we have to respect the patient's decision and keep the patient with us. And remember that our patients don't stay in expert centers nearby. Many of them are from distance and they have to be managed also by their peripheral doctors because they can go into trouble at any time and may not reach us in time. So good communication with the primary team, dissemination of all this expert knowledge, written dissemination, and given to the patient with person in charge or the doctors to contact in terms of emergency is very important. KK, the final word before we ask Justin to take over.
Well, I don't have any final words. I think it's been a wonderful session and I've learned a lot. So Justin, over to you.
Thank you very much, Geetha and KK, for the wonderful case and the wonderful moderation. I think all of you will agree that we had so much of learning The biggest difficult job was how to put the entire learning points in one slide. So much of learning was there that, I hardly thought I could do something in one slide. I think we'll need to write one chapter on management of pregnancy in pulmonary hypertension. But just a very key points. Let us remember, pulmonary hypertension is a very severe progressive disease. Cardiovascular collapse can come anytime. Though it represents an extremely high risk and high risk of maternal mortality, the good news is over a period of time, the last 40 years, studies are showing that the maternal mortality is coming down with improved mortality, improved management, and the newer drugs available. So it is possible that very selected patients, when they are willing, may be permitted to undergo pregnancy, and we can support them. And one important thing is PAH may be presenting for the first time in pregnancy. And pulmonary hypertension continues to be an often misdiagnosis. It's very important to have a high degree of suspicion and suspect pulmonary hypertension. In a pregnant woman, a deadly triad of symptoms is dyspnea, fatigue, and dizziness or giddiness, and syncope. If a patient has all these three, do not ignore this, as this could be cough, or this could be anemia, this could be whatnot. So it's extremely important to have a good echocardiogram. Do not be satisfied with an echo that shows normal LV function, ejection fraction 60%. You have to have a very good RV focused echoes. Cardiologists who are listening, please ensure that when a pregnant woman comes to you for an echocardiographic clearance, please do an RV focus echo. In fact, ERS ESC guidelines suggest 16 points to be mentioned about RV in the echo report and a right heart hemodynamics. And women with pulmonary hypertension need a pre-pregnancy counseling and pregnancy management expert center. I mean, it's an expert center. A lot of us, all the specialties need to be there available. And understanding of the drugs available in the pulmonary hypertension is extremely important. Prostacyclin analogs, I think we need to advocate for its availability in India. A couple of other countries where it is available, it is being extensively used. And in fact, people have got a very, very low mortality of pregnancy in pulmonary hypertension when they are able to use this inhaled as well as more than inhaled intravenous depot prostacyclin infusions. And when the patient deteriorated, this patient deteriorated 27 weeks, but thankfully they were able to manage with Selexipag. But deterioration may not be always due to the disease process. Ensure that we rule out the other secondary causes, a higher BP, a poorly controlled sugar, or anemia. All these things should be ruled out. A delivery plan should be written and made available before between 20 to 30 weeks of pregnancy, ideally before 28 weeks of pregnancy, including the mode of delivery, the induction, the management of labor, delivery and postpartum surveillance, and names of the person who need to be tagged with it. A new anaesthetist, a new cardiologist is better not called all of a sudden. They need to know this patient is going to deliver this particular point of time. We may be called in any time, so that it becomes much more easier. And the pointed out postpartum period is the most critical period. Pain management, fluid management is extremely important. Diuresis is important at the same time. Dehydration is to be avoided. It's extremely important we monitor the fluid status and appropriate management. Rest is extremely important, and we are giving the good rest, and anticoagulation is important. We don't want any DVT to happen and cause a pulmonary embolism. Contraception, extremely important. These women often come back pregnant. It is extremely important. And long-term follow-up. For us, we have to understand that a patient with severe pulmonary hypertension has a shorter natural history, shorter life. Now that the mother had her desire, she had enjoying motherhood. The baby needs a mother now. We have to ensure that the mother lives. So the mother needs to be cared in a pulmonary hypertension center with the expert team, so that we give the best possible medical therapy to her and keep her live long, so that the baby can have the mother. So further, the last word will be multidisciplinary management. The anaesthetist should be brought into the picture much early. A cardiologist who's interested in obstetrics, and anaesthetist who's interested in obstetric anesthesia, particularly experience in cardiac disease management, and an obstetrician interested in this area. It's very important that we may be carried away by interventional cardiology or infertility management, but we need to get our interest in this area, and those people in that centers need to be, every center, I think, need to develop a team for this particular point of work. So the message that I'll give all of you who are listening here is that go get your team. In your center, create a team. It is extremely important. Find out the people and form a team. And along with this, I have the pleasant privilege of expressing the vote of thanks. Dr. Geetha, I think it is quite late for you at Malaysia, and extremely wonderful moderation. In fact, I think she left.
She's here.
You did a great job of moderating and getting the right information from the right time out of the panelists. It was so wonderful. Thank you. Thank you so much, Dr. Geetha. And Dr. KK, I think, there is so much knowledge. I don't know how it was easy for you to hold on all the knowledge that you have in your brain and not let it out. And you saw to it that others were speaking. I really appreciate that, and a wonderful case that you had shared. And the panelists, I don't have any words to thank you. Dr. Shibba, Dr. Chitra, and Dr. Aruna, you did a great job. This only shows that how all the three experts that are very crucially important in managing a woman with the heart disease can join together and support a very sick patient who could have died. I think thanks to the similar team in Dr. KK's place, this woman lived. And Dr. Annie, thanks for the moderation and introduction. And and the Medgami team, thank you so much. And more importantly, participants. I think you are the reason for our motivation. It is your interest that give us the desire to work hard so that we give the best for you. Now, a few information for you participants. Please mark your time. Every first Friday between 8 p.m. to 9 p.m. we'll have the Cardio-Obstetrics Masterclass. We may be having a case discussion, or we may be having a lecture, or we may be even having a journal club discussion. And you are free, we'll be sending you a feedbacks form. Please give the feedbacks so that we can improve our program. And we also have a YouTube channel now called Cardio-Obstetrics. The last month's Cardio-Obstetric presentation by Professor Anita Saxena is now available in the Cardio-Obstetrics channel. I'll share the link to in the Cardio-Obstetric group. Please subscribe to the channel so that you are familiar with that. And today's presentation will be soon available in the Cardio-Obstetrics YouTube channel. There is also a group called Cardio-Obstetrics group. If you are not there, please join. And it is only a Cardio-Obstetric post and nothing else. And please, wherever you are, form a Cardio-Obstetric team and ensure that this particular field comes as a separate subspecialty in India. And thank you very much. Have a great day. Dr. KK, would like to say something?
Yes,
I saw
just
you raised
wanted to
hand.
thank my team. This whole thing is because actually I wasn't to present this. My colleague, Dr. Shine, is the one who manages and he champions the cause of women with heart ailments, and also have another very extraordinary cardiologist, Dr. Navneeta, who looks after these patients. Unfortunately, neither were available. That's why I'm filling in for them. And we have a great team at Amrita. Of course, all the elements were very well represented in our institution, and that's why this patient did well, along with maybe about 30 others who have gone through the similar journey in our institution.
Thank you, Dr. KK. Thanks for the input, and we sincere thanks to the entire team. We have seen Shine's papers on this. Sincere thanks to your team. And I also see a lot of dignitaries in the attendees panel. I could see Professor Hassan, Professor Anita Saxena. Thank you so much. And I also see so much of potential faculties in the attendees. So those of you who are willing to present a case, who have a case where you have which could be useful to the public, if you have an expertise in area, please do not hesitate to contact us, because we are also creating a national and international pool of faculty to provide the best of services for you. And once again, I thank God for this privilege is given to us, to offer this to you in a great platter. Thank you so much. Thank you all once again. Have a great day.
Thank you, sir.
Thank you
so much.
Thank you. Thank you very much.
Thank you, sir.
Are there any unanswered questions? If there are any unanswered questions, we'll answer them and share it in the Cardio-Obstetrics group. Just show that. Can this patient be given a vaginal delivery? I think some of them are there. Well, of course, this patient not. A patient who is quite stable, can be given a vaginal delivery, but definitely not this patient. There are some, in fact, there was one retrospective analysis published recently that patients with heart disease, vaginal delivery has a much better outcome than elective cesarean delivery, and they can be given a trial of labor, but definitely not for this patient. We need to restratify this patient. I think Anita ma'am has given some inputs. I think it has been responded. And Dr. Aruna, would you like to put a central line for, I think she has responded. I think most of them are answered. And some of them are still open. Role of steroids. Tadalafil safe in the first trimester. Yeah, of course. We do give. Class 4 allowed. No, not allowed vaginal delivery. How frequently is we check? Depending on the centers, I think there is no definite protocol as such. But then whenever we see deterioration, definitely we'll have to do the NT-proBNP. And otherwise, I think I personally prefer, if it is available free, at every follow-up visit, we'll do the NT-proBNP. And the 48 hours post-delivery and 7 days post-delivery. In normal women, after 48 hours post-delivery, NT-proBNP generally comes back to normal.
Yes.
There is always a small rise, but then in a sicker patients, it stays in for longer time. How do we manage and monitor auto transfusion post-delivery? Of course, in fact, Dr. Diane Zwick, who is an international authority in pregnancy, she always says that she ensures there is good diuresis in the postpartum. She routinely gives diuretics to ensure that there is a good diuresis postpartum, but not everyone may approve with that strategy. But then, it is always good to look for volume overload, early signs of volume overload, and use appropriate diuresis whenever there is necessary. Role of steroids, I'm not too sure. I think anybody else on the panelists can
Steroids
answer.
for lung maturity.
Oh, okay.
For lung maturity. Because it's 34 weeks, there is no need. But suppose if we had decided on termination 27 weeks, we definitely need to give her steroids. When she was sick at 27 weeks, when we decided, is it possible to wait for 1 more week, we definitely should have given her steroids. But once she's reached 34 weeks, there is no need for steroids.
Do you think magnesium? Magnesium, is there a role for magnesium?
Magnesium.
Yeah, betamethasone is what.
If termination is considered, should be primarily for maternal cardiac status rather for fetal exposure. Okay, maybe this patient who was an ambrycenton, I think it is, of course, for both. If this patient had been terminated in the 2nd trimester as compared to the continuation of pregnancy until viability, what do you feel, Dr. Geetha? What is your comment on this, or Dr. Chitra? The second question: does the risk of maternal morbidity, the first patient, the first pregnancy, first conception, I think terminated at 14 weeks. 14 weeks. So as compared to allowing her to continue the pregnancy, I personally feel 14 weeks termination will be more safer than continuing sicker patient because she was quite sick.
Time.
Yeah.
Normally, we don't advise termination beyond 14 or 15 weeks because it becomes 2nd trimester. Once it becomes 2nd trimester, it's almost like labor. So we don't do a termination. If she crosses that, we tell her to continue the pregnancy and see whatever happens.
Yeah, so terminations have been mentioned to be safe when done in the first trimester.
PH.
Because once it's advanced pregnancy,
ASD closure in this patient, I think for information has been given by Dr. KK. Like all ASDs with pulmonary hypertension, ASDs with pulmonary hypertension, which is irreversible, cannot be closed. Even if you close, the patient may not come out of the theater. That really happened to this patient. They attempted closure for this patient. She could not come, so they removed the closure and reopened the ASD. Then only the patient came off bypass. So not this patient, definitely ASD closure is not an option. Venkatesh and Dr. Venkatesh, vaginal delivery in this situation should really be an option. I think we had discussed.
Yes.
We had discussed magnesium sulfate for neuroprotection. I think
only up to 32 weeks.
32 weeks. Okay. I think all questions are answered.
Someone in the chat has asked for the link, WhatsApp link number, Cardio-Obstetrics group link or number.
Oh, I don't know how to share. Is it possible to share in the group here now? In the chat box? I don't know. Maybe you should. Is it possible to share? I'm not too sure. And
maybe they have given mails to everyone, sir. They can send that number to all the people,
Yeah, we
to
can
all the
definitely
participants. We can share that number to all those who
share
are
that number. We
participating.
can
Yes,
share
sir.
that number.
Yes, sir.
So I think we all good things come to an end, but this is only a beginning for us, and we are just beginning to begin, and we need all of you. I think we'll request all. We are creating a separate group called Cardio-Obstetrics faculty. There nothing else will be posted. Only like, for example, your advice how to take this forward. So I'll be sending an invite to all the faculty to you. Please join the faculty group, and that's it. I think we can close the webinar if everything is okay with you. All of you, it was nice being with you.
Thank you.
Thank you
very
so much, sir.
Thank you very
for the
much.
Thank you, Dr.
opportunity.
Geetha.
And
Thank you, Chitra, ma'am.
And I
Thank you,
forgot
sir.
to thank the
Very
Medgami
excellent,
team. I
panel.
forgot to thank the Medgami team, Vikrant and Shruti. I think you have been doing a great job of doing this for us. Thank you, Medgami. In fact, we have been extremely thankful. And these videos will also be available in Medgami. Thank you so
Maybe
much.
just to add, Dr. Justin, now that we had such a good discussion and a lot of expert care plan for patient with pregnancy, maybe sometimes it'd be good to come up with a care process, you know, like a flow chart or some care processes, and then everyone give their input, and over time you have a whole book that is very user friendly and can be used very practical kind of care flow, something people can refer to, or maybe an app, online or soft copy kind of thing. There's so much
Exactly.
amazing
So
feedback,
much of information. Yes.
something that the cardio-obstetric faculty can think about.
Yeah, definitely. We will, and in fact, we have been thinking about that. We are also in the process of couple of these ones, but including an app also we are working on. But I think this care process, as you said, today's your idea is a great one. We should definitely look into it and work on that.
Thank you.
And we'll discuss that in the cardiac faculty group.
Thank you.
So thank you so much.
Thank you so much.
Thank you, everyone.
Thank you, Madgami team.
Good
Thank you.
weekend, everyone. Thanks for your input. Thank you. Thanks, Justin. Thank you for the
Thank you. Thank you. Thank you, sir. Bye-bye.
opportunity. Thank you, sir.